Thank you, Andrew. And I'm presenting this on the behalf of a large group of colleagues and the Study of Prevention of Anal Cancer Study Team based in Sydney. The only relevant disclosures relate to the fact that a few of the investigators have done research and other work for the manufacturers of the HPV vaccine. So over the next 12 minutes, I'm going to work through these subheadings. Firstly, talk about why we're doing, in this day and age, a natural history study. Talk about the study of prevention of anal cancer, otherwise known as SPANC, and the results as they relate to high-grade squamous lesions, and then talk a little bit about the implications of these findings. So some of you will come from settings where you treat high-grade anal lesions or HSIL. In Australia, we don't do this for at least three major reasons. So firstly, this disease is extraordinarily prevalent in HIV-positive gay men, in the order of 30 to 50%, according to a recent meta-analysis. Treatment is extremely difficult. The largest randomised trial in the field, published in 2013, showed recurrence rates of about 50% at 1 year and in fact about 70% at 2 years, with 20 to 40% of men experiencing grade 3 to 4 side effects. And a Cochrane review conducted in 2012 concluded there was no evidence-based evidence of effectiveness. And lastly, the progression rate of to cancer, as estimated from a comparison of prevalent HSIL to incident cancer, is apparently much less than in the cervix, in the order of 1 in 400 per year in HIV-positive gay men and in about 1 in 4,000 per year in HIV-negative gay men. What can a natural history study add? So we're really interested in two key outcomes here. Does high-grade lesions, do they spontaneously clear, and how often? And could that possibly explain, could a common rate of clearance explain why we don't see as much cancer as we might otherwise explain? And conversely, we want to look at who gets long-term persistent high-grade disease and what predicts that, because they, we would presume, would have a much higher risk of progressing to cancer. So the SPANC study is a community-based study based in Sydney, and it recruits HIV-positive and negative homosexual men aged older than 35. So we're really interested here in the age group that's at risk of anal cancer. They have 5 visits over 3 years, at baseline 6 months, and then at 3 annual follow-up visits. And at each visit, they have an anal swab, which is tested for HPV using the Roche linear array and cytology based on ThinPrep. And at each visit, these brave souls undergo a high-resolution anoscopy with biopsy of any visualised lesion. So at each visit, they get both cytology and high-resolution anoscopy. And we will complete recruitment in July of next year when we reach our target of 600. So these are interim results I'm presenting today. There are a few acronyms in this field which you need to be aware of before I go on. So we're talking about cytology and histology results, and I'm going to be talking about squamous intraepithelial lesion, SIL. The next one up is cytology results, is ASCUS, or atypical squamous cells of uncertain significance, low-grade lesions, or LSIL, which on histology can also be called anal intraepithelial neoplasia, grade 1, which I'll call AIN1. The next step up is ASCH, so atypical cells where high-grade disease cannot be ruled out on cytology, and high-grade disease, which I'll call HSIL. And histologically, that can be divided into 2 grades, just the same as cervical disease is 2 and 3, with 3 being the most severe. So the HSIL endpoint is not as straightforward as in the cervix because both cytology and high-resolution anoscopy are known to undercall total high-grade disease. So we used a composite endpoint of HSIL on either histology or cytology to get a maximally sensitive measure of high-grade disease. And in the analysis I'm presenting today, ASCH is not included as HSIL. We actually have done sensitivity analysis including it as HSIL, and the results are quite similar. In terms of incidence, we're talking about transition from cytology of less than ASCH and high-resolution anoscopy that is normal, or a biopsy that shows low-grade disease only, or normal histology, progressing to a cytological or a histological diagnosis of high-grade disease. And clearance is simply defined as the inverse of that. So moving on to the results, and firstly, prevalence. You can see we've got 450 men enrolled at the study at the moment. Median age is 49 and about a third are HIV positive. No difference between the two groups in cytological high grade, but HIV positive men have substantially more high grade disease as defined histologically, and that is driven by a higher rate of the most advanced form of HSIL or AIN3. When you put the cytology and the histology data together, you get rates of composite high-grade disease of 46% in positive men and 34% in negative men. Incidence. So we calculated this in men who were free of high-grade disease at baseline. We included nearly 200 men in this analysis, followed for close to 300 person years, and for 45 incidence cases, or 16 per 100 person years. So 1 in 6 men who did not have high-grade disease at baseline developed it each year. In terms of predictors, if you were to look in this in women, you would find much higher rates in the young than in the old, but we didn't find much of a trend, certainly no significant trend as age increased in our cohort. We did find that HIV positive men had higher rates, but this has not yet quite reached significance in our study. And rates of progression were higher from the abnormal states, from low-grade disease or ASK-H, than they were for progression from normal status. In terms of HPV status, as you would imagine, high-risk HPV is a very, very strong risk factor, and these first are baseline high-risk results. So whether you measure it as any high-risk HPV, the number of types of HPV, and HPV 16 or 18, you find strong relationships. In terms of longitudinal measures of HPV, so this is measures of HPV at baseline and the most recent measure of high-risk HPV. Firstly, in relation to any high-risk HPV, you'll see here that incidence of high-grade disease is much more common in those men who develop a high-risk HPV infection or who have a chronic HPV infection, so 20 to 30 per 100 person years, than in other men. And of course, it's very rare, as you would hope it would, in men who don't have high-risk HPV infection. And a similar pattern is found for HPV 16, which is the primary cause of anal cancer, causes about 85% of anal cancer, with highest rates in men who either develop a new infection or who have a chronic infection with HPV 16. Clearance of high-grade disease. So this is what we as a natural history study can do that studies of treatment obviously cannot do because they treat. So we included 112 men who had a high grade of high-grade disease at baseline in this analysis for about 150 person years. And the clearance rate was very, very high indeed. So 42 per 100 person years. In other words, over 40% of men with a high-grade disease will lose it spontaneously after a 1 year period. What were the predictors of this? So age was not related. Interestingly, HIV status was not related. So HIV status predicted incidence but not clearance. And having more severe disease, having AIN3, you were less likely to clear a high-grade disease. And lack of HPV was very, very strongly related to clearance of these disease. So if you had a high-risk HPV, you were nearly 5 times less likely to clear. The more types of HPV you had, the less likely you were to clear. And men with HPV 16 were much less likely to clear. These longitudinal measures, you'll see here that men who didn't have the high-risk HPV types were likely to clear, and it became progressively less likely. So men with chronic high-risk HPV infection, very unlikely to clear their high-grade disease. So in conclusion, we've certainly documented, as others have done, that high-grade is very, very prevalent in homosexual men. About half of HIV-positive homosexual men and a third of HIV-negative homosexual men. What we've been able to show is that high-grade disease is very highly dynamic, reflecting dynamic HPV infections and clearances. So 1 in 6 men getting it, and then of those men who get it, about 40% clearing it per year. And this is very closely associated with high-risk HPV, so that incident high-grade disease is uncommon in those without chronic or new HPV infection. Clearance is usual in those who don't have high-risk HPV infection, and uncommon in those who have a chronic HPV infection. And lastly, the implications of these findings. So we think these data provide a very, very strong justification for the fact that not all high-grade anal disease requires treatment. With such a high prevalence and such a high clearance, we think that justifies that position. We think these data suggest that treatment can be targeted at those with persistent high-grade disease. And I would also add that I think they suggest that treatment studies could be focused on those with persistent high-grade disease, because much high-grade disease diagnosed on a single occasion will simply go away. And the treatment trials should have a no-treatment arm comparator. The close links with high-risk HPV suggest that repeated HPV testing may have a role in the full assessment of high-grade disease before treatment, and that biomarkers which might be able to predict persistent infection at a single point in time, at a single test, need to be investigated. I'd just like to finish by acknowledging the very large team. It takes a village to run a study like SPANC, and some of them are here in the audience, so thank you very much to them, and a couple of posters on the SPANC study that are at the conference. Thank you.